Welcome to this comprehensive educational session on gout, brought to you by ClinMed Compass. I am Dr. Morike, and today we will be exploring the pathogenesis, clinical presentation, diagnosis, and evidence-based management of gout, a crystal-induced inflammatory arthritis that every clinician should understand. This presentation is designed for medical students, resident doctors, and other healthcare trainees. By the end of this session, you will have a solid foundation to recognize, diagnose, and manage gout in clinical practice. If you haven't subscribed to ClinMed Compass, kindly do so, like and also share our videos to friends and colleagues. So grab your pen and paper and let's get started. Gout is a crystal-induced inflammatory arthritis. The key word here is crystal-induced. The inflammation is not autoimmune, like rheumatoid arthritis, and it is not infective, like septic arthritis. It is driven by deposition of monosodium urate crystals. It is best described as a metabolic disease with a rheumatologic expression. In other words, the root problem is abnormal uric acid metabolism, but the patients present with a joint disease. Clinically, gout is strongly associated with chronic kidney disease, metabolic syndrome, and cardiovascular disease. So, whenever you see a patient with gout, you should think beyond the joint and assess the patient's kidneys, blood pressure, lipids, weight, and overall cardiovascular risk. Gout is defined as a crystal-induced inflammatory disease characterized by persistent hyperuricemia and deposition of monosodium urate crystals in joints and tissues. These crystal deposits produce different clinical manifestations. The patient may present with acute gouty arthritis, which is the classic painful red, swollen joint. Over time, if untreated, the patient may develop chronic tophaceous gout with visible tophi and joint destruction. The kidneys can also be affected, leading to urate nephropathy and uric acid kidney stones, also known as nephrolithiasis. So gout is both a joint disease and a systemic disease. Gout is one of the most common inflammatory arthritis in adults worldwide, and its prevalence is increasing due to aging populations, rising obesity, and increasing metabolic disease. It is more common in men and in postmenopausal women. The typical age of onset is between 30 to 60 years. Before menopause, women are relatively protected, which explains the male to female ratio of about 2 to 7 to 1. Gout is strongly associated with chronic kidney disease, obesity, metabolic syndrome, and cardiovascular disease. Importantly, gout is not just a bystander. It's an independent risk factor for cardiovascular mortality. Uric acid is the final end product of purine metabolism in humans. Unlike some animals, humans lack the enzyme uricase, so uric acid accumulates as the final product. Purines come from two main sources. The first is endogenous sources, mainly from cell turnover and normal nucleic acid metabolism. The second is exogenous, from the diet, especially red meat, organ meat, seafood, and alcohol. Biochemically, purines are converted to hypoxanthine, then to xanthine, and finally uric acid by the enzyme xanthine oxidase. Once formed, uric acid is eliminated mainly by the kidneys, which handle about 2/3, while the gut handles about 1/3. Let's zoom in on the renal handling, because this is where most hyperuricemia originates. The kidney processes urate in 4 key steps. First, glomerular filtration. Uric acid is freely filtered. Second, about 90% is reabsorbed in the proximal tubule. Third, approximately 60% is secreted back into the tubule. And fourth, 80% of that secreted uric acid undergoes post-secretory reabsorption. The net results, only about 10% of filtered uric acid is finally excreted in urine. Any defect at any of these steps, whether genetic or acquired, can reduce excretion and lead to hyperuricemia. This explains why renal impairment is such a strong risk factor for gout. Uric acid transport is mediated by specific transporters. The urate transporter 1 and glucose transporter 9 are mainly responsible for reabsorption of uric acid back into the blood. Organic anion transporter 1 and organic anion transporter 3 are involved in secretion of uric acid into the tubules. Genetic or acquired defects in these transporters reduce uric acid excretion and lead to hyperuricemia. Hyperuricemia is defined as serum uric acid level above 6 mg per deciliter in females and above 6.5 mg per deciliter in males. The critical saturation point is about 6.8 mg per deciliter. Above this level, uric acid crystals can form. However, it is very important to remember two exam and clinical facts. First, hyperuricemia does not equal to gout. Many people have high uric acid levels and never develop gout. Second, a normal uric acid level does not exclude gout, especially during an acute attack. In reality, less than 25% of hyperuricemic patients develop gout, and the risk increases with higher uric acid levels and longer duration of hyperuricemia. Hyperuricemia can be classified in two complementary ways. First, by etiology, as primary hyperuricemia, which is idiopathic or genetic, often presenting without another clear cause. Secondary hyperuricemia is acquired, resulting from another disease, medication, or lifestyle factor. Second, by mechanism. About 10% of hyperuricemic cases stem from uric acid overproduction and 90% from under-excretion, and some patients have a combination of both. This makes the under-excretion group the dominant mechanism in gout. By urinary urate excretion, overproduction is defined as more than 800 mg per day, while under-excretion is less than 600 mg per day. Let us walk through this comprehensive table of causes of hyperuricemia. On the left, we have urate overproduction. Primary causes include rare genetic enzyme defects like hypoxanthine guanine phosphorybosis transferase deficiency, seen in Lesch-Nyhan syndrome, and phosphorybosis pyrophosphate synthetase overactivity. Secondary causes are more common: high purine diets, alcohol, fructose consumption, myeloproliferative disorders, leukemia, hemolysis, psoriasis, tumor lysis syndrome, chemotherapy, and glycogen storage diseases. On the right, causes of uric acid under-excretion. Primary forms could be idiopathic or uric acid genetic transporter defects. Secondary includes chronic kidney disease, acute kidney injury, dehydration, metabolic acidosis, hypertension, endocrine disorders like hypothyroidism, hyperparathyroidism, and importantly, medications like diuretics, cyclosporine, tacrolimus, pyrazinamide, ethambutol, and others. Lead nephropathy is a classic but often overlooked cause. Keep this table handy. It's a differential diagnosis checklist for hyperuricemia. A quick but important addition. Some conditions cause both overproduction and under-excretion of uric acid simultaneously. Alcohol is the prime example. It increases purine breakdown while impairing renal excretion. Similarly, certain enzymes deficiencies like glucose 6-phosphate deficiency, as we found in von Gerker's disease, or fructose 1-phosphate aldolase deficiency. Recognizing this overlap helps avoid oversimplification in complex patients. This table organizes risk factors into non-modifiable and modifiable categories. Non-modifiable include male sex, increasing age, genetic predisposition, and family history. Modifiable include factors such as obesity, metabolic syndrome, alcohol, especially beer, high intake of red meat and seafood, fructose-sweetened beverages, hypertension, chronic kidney disease, diabetes, and medications like diuretics, aspirin, and cyclosporine. As clinicians, our focus should be on modifying what we can. Lifestyle counseling, medication review, and comorbidity optimization can significantly reduce gout risk and severity. Even in patients with chronic hyperuricemia, acute gout attacks often have identifiable triggers. Common precipitants include trauma, recent surgery, alcoholic binges, fasting, dehydration, starting urate-lowering therapy without prophylaxis, and rapid rise or fall in serum urics. The pathogenesis of acute attack of gout starts with hyperuricemia, leading to the formation of monosodium uric acid crystals. These crystals deposit in joints and in tissues. Now, neutrophil and monocytes phagocytose these crystals and in turn activate the innate immune system. Specifically, the toll-like receptors upregulate to pro-interleukin-1 beta, and the NLRP3 inflammasome is activated, leading to capsis-1 activation. Capsis-1 then cleaves pro-interleukin-1 beta into active interleukin-1 beta, a potent pro-inflammatory cytokine. Interleukin-1 beta drives neutrophil influx, endothelial activation, and increased vascular permeability and amplification of the inflammatory cascade. The clinical result is severe pain, swelling, redness, and warmth. These are classic signs of acute gouty arthritis. Acute attacks are self-limiting, typically resolving within 10 to 14 days. How does resolution occur? Monocytes differentiate into macrophages, which shift the cytokine profile from pro-inflammatory to anti-inflammatory producing molecules like transforming growth factor beta. Additionally, plasma proteins such as apolipoprotein coat the urate crystals, making them less recognizable to immune cells and thus less inflammatory. This natural resolution is why some patients delay seeking care. But remember, each untreated attack contributes to cumulative joint damage. If hyperuricemia persists, crystal deposition continues, and crystals aggregate and form tophi. Chronic inflammation then leads to progressive cartilage destruction, bone erosion, joint deformity, and chronic synovitis. This is the basis of chronic tophaceous gout and irreversible joint damage. Gout progresses through 4 classic stages. First, asymptomatic hyperuricemia. Here you have elevated urate levels without symptoms. Second, acute gouty attack. This is the first painful attack. Third, intercritical gout. Here we have symptom-free intervals between attacks, but biological active disease continues. Fourth, chronic tophaceous gout. Here there is persistent inflammation, visible tophi, and joint destruction. Not all patients progresses through every stage, especially with timely treatments. Asymptomatic hyperuricemia. This stage is characterized by elevated serum uric acid without symptoms. It is often discovered incidentally during routine investigations. Many patients remain in this stage for years and may never develop gout. This is why treatment at this stage is controversial. However, the higher the uric acid level, the greater the risk of progression. Acute gouty arthritis is dramatic in presentation. Onset is sudden, often waking patients from sleep with severe pain. The affected joints become swollen, erythematous, and warm. Symptoms peak within 12 to 24 hours and, untreated, resolve over days to 2 weeks. A hallmark is extreme tenderness. Patients may report bedsheet intolerance, where even light contact is excruciating. Skin erythema may mimic cellulitis, and systemic symptoms like fever may occur. The classic site of acute gout is first metatarsophalangeal joint, podagra. Other sites include ankle, knees, midfoot, wrist, and elbow. Monoarticular presentation is typical early in the disease. On this slide, you can see the clinical photographs of acute gout affecting the first metatarsophalangeal joints, what we call podagra, as well as the ankle joints. You will notice the redness, swelling, and tense, shiny skin. This is typical of acute gout. Clinically, this appearance can easily mimic cellulitis or septic arthritis. That is why, in practice, you should never rely on appearance alone. Always think about the differential diagnosis and consider joint aspiration when in doubt. Intercritical gout refers to the symptom-free period between acute attacks. The important point here is that even though the patient feels well, the disease is still active at a biological level. Crystals continue to deposit silently in the joints and tissues. Over time, if hyperuricemia is not controlled, attacks become more frequent, involve more joints, and last longer. This stage is your opportunity to intervene and prevent progression to chronic gout. Chronic tophaceous gout develops after years of uncontrolled disease. At this stage, patients have persistent inflammatory arthritis and visible tophi, which are collections of uric acid crystals in soft tissues. Tophi commonly occur at the ear helix, olecranon bursa, Achilles tendon, fingers, wrists, and toes. These tophi can ulcerate, become infected, compress nerves, and cause severe pain, deformity, and functional limitation. This stage represents advanced but preventable disease. These images illustrate chronic tophaceous gout with obvious joint deformity. On the left, you see multiple tophi visible on the fingers. Note the nodular yellowish subcutaneous deposits. On the right, you also see multiple tophis visible and foot deformity due to chronic gout. Here you can see tophi on the ear helix and over the olecranon bursa. These are classic sites because they are cooler areas of the body, and urate crystals tend to deposit more easily in cooler tissues. Clinically, these tophi are often firm, irregular nodules, and sometimes be mistaken for rheumatoid nodules or other soft tissue lumps. Gout is not limited to the joints. It can cause uric acid kidney stones, chronic urate nephropathy leading to chronic kidney disease, and acute uric acid nephropathy, especially in settings like tumor lysis syndrome. Gout is also strongly associated with hypertension, diabetes mellitus, dyslipidemia, obesity, and cardiovascular disease. So, managing gout properly also means managing the patient's overall metabolic and cardiovascular risk. The diagnosis of gout is based on clinical assessment and, most importantly, crystal identification. The gold standard is finding intracellular monosodium urate crystals in synovial fluid or in a tophus. A very important clinical rule is always exclude infection. Septic arthritis can look exactly like acute gout, and missing it can be catastrophic. Synovial fluid analysis is diagnostic, Under polarized light microscopy, monosodium urate crystals appear needle-shaped and negatively birefringent. They appear yellow when parallel to the compensator axis and blue when perpendicular. Synovial white cell count is typically elevated, often above 15,000 per microliter, with neutrophil predominance. However, counts above 50,000 per microliter should raise suspicion for septic arthritis. So always send gram stain and culture. This micrograph shows the hallmark of gout monosodium urate crystals under polarized light. Observe the slender needle-shaped crystals. They are negatively birefringent. Some are intracellular within neutrophils, while others can be extracellular. Also note the yellow color of the crystals and the blue colors of the crystals depending on their orientation. Recognizing this pattern distinguishes gout from pseudo-gout, where calcium pyrophosphate crystals are rhomboid shaped and positively birefringent. Serum uric acid is supportive but not diagnostic. It is often elevated, but it can be normal during an acute attack due to inflammatory shifts. So, two key exam points. A normal uric acid level does not exclude gout, and hyperuricemia alone does not diagnose gout. Other blood tests help assess inflammation and comorbidities. Erythrocyte sedimentation rate and C-reactive protein are usually elevated. The full blood count may show neutrophilic leukocytosis. Renal function is essential because it guides drug choice and dosing. Lipid profile and liver function tests are important because of metabolic associations and before starting long-term therapy. Imaging complements clinical and laboratory findings. X-rays early in the disease may be normal or show only soft tissue swelling. Late findings include punched-out erosions with overhanging edges, the classic rat bite lesion. Tophi may also be visible on radiographs. Ultrasound is increasingly valuable. The double contour sign, a hyperechoic band over the cartilage, indicates urate deposition. Ultrasound also visualizes tophi and guides aspiration. Dual energy CT can detect uric deposits even when aspiration isn't feasible. MRI and CT scan help assess bone erosions and soft tissue involvement. Choosing the right modalities depends on the clinical context and availability. This ultrasound image demonstrates the double contour sign, a highly specific finding for gout. You see the hyperechoic irregular line indicating the urate deposits. You also see it here, okay? Overlying an anechoic hyaline cartilage of the joint surface, creating a double appearance. This sign actually can be detected even before symptoms appear, making ultrasound a very, very powerful tool for early diagnosis and monitoring. This X-ray shows classic punched-out erosions with overhanging edges, sometimes described as the rat bite sign. These are characteristics of chronic gout and reflects long-standing crystal-induced bone damage, as indicated in the red circle and the arrows. This dual energy CT image highlights urate deposits in green. You can see them. These are urate deposits. This one in the Achilles tendon. Okay. This technique is especially useful when joint aspiration is not possible or when the diagnosis is uncertain. Gout mimics many conditions, so a broad differential is essential. Septic arthritis is the most critical to exclude. It's an emergency. Pseudo-gout, that is, calcium pyrophosphate dihydrate crystal disease, presents similarly, but with different crystals. Cellulitis can mimic gout erythema, but lacks joint involvement. Rheumatoid arthritis typically causes symmetrical polyarthritis. Trauma or hematrosis may cause acute monoarthritis. Psoriatic and reactive arthritis have distinct patterns. Osteoarthritis flare can cause pain, but less inflammation. Effective gout management has 4 interconnected goals. First is rapidly treat the acute attack to relieve pain and inflammation. Second, prevent reoccurrences through lifestyle and pharmacologic strategies. Third, lower the serum uric acid long-term to dissolve crystals and prevent new deposition. This is the cornerstone of disease modification. Fourth, prevent complications like Tophi, joint damage, and renal disease. It is important to state that treatment should be started early, usually within 24 hours of symptom onset, for best outcome. These goals guide every therapeutic decision we make. For acute attacks of gout, it is essential to take care of the pain and inflammation. Several options include non-steroidal anti-inflammatory drugs, which are first line for many patients. Colchicine, it's highly effective if started very early. Corticosteroids, be it oral, intra-articular, or parenteral, are excellent alternatives, especially with renal impairments. Adrenocorticotropic hormone is an underused option. For refractory cases, interleukin-1 inhibitors like anakinra offer targeted therapy. Choice depends on patient factors such as age, renal function, comorbidities, and contraindications. Non-steroidal anti-inflammatory drugs works best when started early in an acute attack. Common choices include ibuprofen, naproxen, indomethacin, amongst others. Continue until the attack fully resolves, but use caution. Avoid NSAIDs in patients with peptic ulcer disease, chronic kidney disease, heart failure, hepatic insufficiency, or bleeding disorder. Always consider gastroprotection in high-risk patients. NSAIDs are effective but not risk-free. Colchicine is most effective within the first 12 hours of symptom onset. Its mechanism includes inhibiting microtubule polymerization, which impairs neutrophil chemotaxis and activation. Modern low-dose regimen minimize side effects. 1.2 gram initially, followed by 0.6 or 0.5 milligram 1 hour later, then 0.6 milligram once or twice daily until resolution. Side effects include diarrhea, abdominal cramps, and vomiting. Myopathy is rare but serious. Dose adjustment is essential in chronic kidney disease, liver disease, and in the elderly. Corticosteroids. Corticosteroids are versatile for acute gout. Oral prednisolone, around 10 to 20 milligrams daily, is effective for polyarticular attack. Intra-articular injection is ideal for monoarthritis after infection is excluded. Intravenous or intramuscular routes suit severe or systemic presentations. Steroids are particularly useful in renal impairment, where NSAIDs and colchicine may be contraindicated. Use with caution in diabetes and heart failure. Always exclude sepsis before injecting steroids into a joint. When used appropriately, steroids provide rapid, reliable relief. For complex or refractive cases, consider adrenocorticotropic hormone, around 40 to 80 international units every 12 hours for up to 3 doses. It stimulates endogenous cortisol production. Interleukin-1 inhibitors like anakinra block the key cytokine in gout pathogenesis and are reserved for severe treatment-resistant cases. Now we discuss uric acid lowering therapy. Urate-lowering therapy is the cornerstone for long-term gout management. The target serum urate is less than 6 mg per deciliter for most patients and less than 5 mg per deciliter in those with tophaceous or severe gout. This is what we mean by treat-to-target approach. Uric acid lowering therapy medications fall into three main classes. First is the xanthine oxidase inhibitors, Allopurinol and Febuxostat, which reduce uric acid production. Second are the uricase or the uricolytic agents like pegloticase and rasburicase, which enzymatically break down uric acid. Third are the uricosurics, probenecid, sulfentrazone, and lesinurad, which increase renal uric acid excretion. Additionally, some drugs have mild uricosuric effects like losartan, fenofibrate, and clofibrate. Understanding these mechanisms help us choose the right medication for the right patient. When should we start urate-lowering therapy? Key indications include 2 or more attacks per year, that is, more than 1 attack per year, presence of Tophi, chronic kidney disease stage 2 or higher, chronic gouty arthritis, recurrent uric acid stones, chronic urate nephropathy, radiographic erosions, very high serum urates, greater than 10 mg per deciliter in females and more than 30 mg per deciliter in males, or high tumor lysis risk. Take note of the following golden rules. First, do not start urate-lowering therapy during an acute attack. This can prolong or worsen inflammation. Second, do not stop established urate-lowering therapy during a flare. Stopping can trigger rebound hyperuricemia. Third, start urate-lowering therapy 3 to 6 weeks after flare resolution. And always give flare prophylaxis when initiating therapy. Allopurinol is first-line urate-lowering therapy. As a xanthine oxidase inhibitor, it reduces urate production. Start low, 100 mg daily, however lower in chronic kidney disease, and titrate up every 2 to 5 weeks based on serum uric acid response. Monitor serum uric acid, renal and liver function regularly. Reduce dose in renal impairments. Screen for HLA-B5801 in high-risk population like the Han Chinese, Korean, or the Thai patients due to the risk of severe allopurinol hypersensitivity syndrome. Febuxostat is a non-purine xanthine oxidase inhibitor, an alternative for allopurinol intolerant patients. It's more potent at lowering uric acid and is hepatically metabolized, making it very useful in mild to moderate chronic kidney disease without dose adjustments if the eGFR is greater than 30 mL per minute. Start at 40 mg daily and may increase to 80 mg if needed. Febuxostat has been suggested to have an increased cardiovascular risk, so use with caution in patients with cardiovascular disease. Uricosuric agents. Uricosurics work by inhibiting renal tubular reabsorption of uric acid, thereby increasing excretion. Examples include probenecid, sulfentrazone, benzbromarone, and lesinurad. Requirements for use are good renal function, usually eGFR greater than 50 mL per minute, and high fluid intake to prevent stones. Contraindications include moderate to severe chronic kidney disease and history of uric acid stones. These agents are particularly useful in under-excretors and can be combined with xanthine oxidase inhibitors for refractory cases. Always assess renal function before prescribing. Some commonly used drugs have modest uricosuric effects. Losartan used for hypertension, fenofibrate and clofibrate for dyslipidemia, and vitamin C at high doses. These can serve as helpful adjuncts in selected patients, especially those with comorbid hypertension and hyperlipidemia. Uricosurics may increase the risk of renal stones, so ensure adequate hydration. Uricase agents represent a powerful option for severe refractory gout. They convert uric acid to allantoin, which is far more soluble. Pegloticase, a recombinant uricase given by intravenous infusion, is indicated in severe tophaceous gout or responsive to conventional therapy. It can also prevent hyperuricemia in patients on chemotherapy. Rasburicase is used prophylactically in tumor lysis syndrome. Limitations include infusion reactions, antibody formation that can reduce efficacy, and high costs. Initiating uric acid lowering therapy can paradoxically trigger acute flares by mobilizing crystal deposits. Therefore, flare prophylaxis is mandatory. Options include low-dose colchicine or low-dose nonsteroidal anti-inflammatory drugs. Duration is a minimum of 3 to 6 months, or longer if tophi are present or disease remains active. Never start urate-lowering therapy without a prophylaxis plan. It's a common error with preventable consequences. Pharmacotherapy works best alongside lifestyle optimization. Counsel patients on the following: weight reduction, which lowers uric acid production; adequate hydration to promote excretion; reducing alcohol, especially beer, red meats, and seafood; limiting fructose-sweetened beverages; and increasing low-fat dairy intake. Then you optimize comorbidities. You control hypertension, diabetes, and dyslipidemia. Review medications that raise uric acid and consider alternatives. Importantly, lifestyle changes support but do not replace drug therapy. Untreated or poorly controlled gout leads to serious complications. Musculoskeletal may cause chronic erosive arthritis, joint deformities, tendon rupture, tophi ulceration or infection, and nerve entrapment syndromes. In the renal system, nephrolithiasis and chronic urate nephropathy contributing to chronic kidney disease. They have systemic complication, increased cardiovascular risk, and functional disability affecting quality of life. Prognosis is excellent if serum uric acid is controlled and the patient adheres to therapy. It is poor if untreated, with recurrent attacks, tophi formation, and progressive disability. To wrap up this lecture, here are essential take-home messages. Gout is a crystal-induced inflammatory arthritis driven by monosodium urate deposition. Under-excretion is the commonest cause of hyperuricemia. Serum uric acid may be normal during acute attack. Don't be misled. Crystal identification confirms diagnosis. Treat acute attacks promptly with NSAIDs, colchicine, or steroids. Start uric-lowering therapy only when indicated, using allopurinol as first line. Treat to target serum uric acid levels to dissolve crystals and prevent complications. And remember, early sustained therapy prevents irreversible damage. Master these principles and you will excel in managing gouts. Thank you for joining me in this comprehensive exploration of gout. I hope this session has equipped you with the knowledge and confidence to recognize, diagnose, and manage this common yet complex condition. Remember, gout is highly treatable, and your intervention can prevent significant morbidity. If you have questions, revisit the learning objectives or reach out through ClinMed Compass. Keep learning, keep questioning, and keep providing excellent patient care. This is Dr. Emorike signing off. Thank you.